Righty, let's talk about oncology. So, cancer. I think most people probably know someone in their life who has had cancer. Everyone is impacted by this disorder in some sort of way. And the way that cancer progresses is it begins in the initiation period. So, the initiation phase of cancer is when the gene first becomes cancerous. Not all cells are cancer cells, but all cells can become cancer cells. Once the cell becomes cancerous, it moves into the promotion phase, and this is where the cancerous cell has increased cellular growth and it doubles. Once it starts to grow, it moves into the progression phase, and this is where the cell becomes more malignant. It'll develop its own blood supply, and then finally, it'll metastasize or move to other areas of the body. Cancer can be poor or well differentiated. Poor differentiated is when the cancer is more aggressive, and well differentiated is when the cancer is less aggressive. And then we also look at ploidy, which is the description of the chromosome number and appearance of those cells. So, what is leukemia? Leukemia is a blood cancer when we have uncontrolled immature white blood cell growth, and this is your blast cells in your body. So patients with leukemia may bruise easily, they might have nosebleeds, hematuria or blood in their urine, their gums can bleed easily, and then we're also going to see low hemoglobin and hematocrit levels. For leukemia patients, we're going to do daily blood counts. We're going to inspect their mouth for sores, do vital signs every 4 hours, encourage the use of incentive spirometry, and then patients who are undergoing like chemotherapy or radiation are going to be extremely immunocompromised. So we want to do anything that we can to reduce exposure to different bacteria. So one thing that we might encourage is not having any flowers or standing water in the room. We might avoid like fresh vegetables or fruits that are brought in that their grandma grew in their backyard. And then we also want them to frequently wash their hands and avoid large crowds. So we wouldn't encourage these patients to go to like a big concert or a sporting event. We have 4 different types of leukemia. So the first one is ALL, which is acute lymphocytic leukemia. Typically, ALL is diagnosed at a younger age. It's not super frequent that we'll see this in older adults. ALL affects the Philadelphia chromosome, and we treat this with methotrexate. Then we also have CLL, which is chronic lymphocytic leukemia, and this one is typically a little bit older of adults. We're going to implement watchful waiting, so that's when we just sit around and wait for it to get to a point where we can actually treat the cancer. When patients are under 66 years old, they might get a stem cell transplant to treat this. AML is acute myeloid leukemia. This is typically seen in males, and usually we see this over the age of 72. We treat AML with 4 to 6 weeks of cytarabine, idarubicin, and daunorubicin. And then we also have CML, which is the chronic version. This is typically also males over the age of 65. And we treat CML with tyrosine kinase inhibitors, which are also known as NIBs. When a patient is taking NIBs, we want to encourage them to avoid grapefruit juice and pomegranate juice. And then we also don't want them to take NIBs when they are pregnant. Remission for leukemia is defined as when there are less than 5% of blast cells that make up, like in all of the blood cells, less than 5% of them are going to be blast cells. Next, we have lymphomas. So patients with lymphomas are usually going to come in and complain about painless like nodes. Usually it's kind of in the neck area, so they might have a big lump here that doesn't hurt them at all. They might be waking up at night just pouring in sweat. They might be running a fever. And then we might also see unintentional weight loss. So there's 2 types of lymphomas. We have Hodgkin's lymphoma, which is typically seen in younger adults. And we treat Hodgkin's lymphoma with ABVD chemotherapy. And then once that's complete, we'll usually do a round or 2 of IFRT. We also have non-Hodgkin's lymphoma, which is seen in adults over the age of 60. And the big diagnosable difference between the 2 is that non-Hodgkin's lymphoma has no Reed-Sternberg cells. So non-Hodgkin's, no Reed-Sternbergs. So to treat cancer, we have a couple of different options. Most commonly, you'll see chemotherapy and radiation. For chemo, you have neoadjuvant and adjuvant therapies. So adjuvant therapies are going to be used after a patient has had surgery to remove cancer. So adjuvant therapy goes in and kills the cancer cells that were not removed by surgery. Neoadjuvant is going to work before surgery. So we're not going to be giving this one after. Complications that you'll see with chemotherapy include neutro and thrombocytopenia. So we're going to see decreased cell counts. They might have a fever over 100.4. They might have inflammation of the mucous membranes, SIADH, so they might be holding on to a bunch of fluids. And then we may also see spinal cord compression. Something else frequently used is radiation. This can be done internally or externally, and radiation may cause dermatitis, dry mouth, and then you may also see bone marrow suppression. When you are caring for a patient undergoing radiation, we want to make sure that we're wearing that lead apron and then the dosimeter badge to kind of let us know how much we've been exposed to. We want to put a sign outside the patient's door so that people know that there's radiation inside. And then we really want to discourage people who are under the age of 16, pregnant, or trying to conceive from visiting a patient going through radiation. Something else that you might see done is a bone marrow aspiration. So this is done by putting the patient in either the prone or the sideline position, and then we will expose the iliac crest and get a sample. Patients are receiving this under a local anesthetic, and afterwards we want to encourage site monitoring every 2 hours for the first 24 hours. Patients who have a bone marrow aspiration are going to be told to avoid aspirin, blood thinners, and then we also just want to restrict exercise right away. Some emergencies that you might see in patients with cancer. The first one is DIC, or disseminated intravascular coagulation. In DIC, blood clots are forming, and that actually sucks up all of the body's clotting factors, and so the patient's at very high risk for bleeding. In superior vena cava syndrome, or SVC, all of the circulating blood from the upper body is going to be returned to the heart. This condition is usually worse when the patient is in the supine position or when they're directly on their back. And patients may have periorbital edema or swelling around the eyes. They may feel like their head is really full. Their level of consciousness may decrease. Their blood pressure may decrease. And then we might also notice some cyanosis. Last but not least, we have tumor lysis syndrome. So this is when tumor, ignore my spelling typo there, tumor cells are destroyed faster than the body can get rid of the waste. So we're going to kind of see a buildup of that waste product in the body, and this may lead to high potassium and uric acid levels. So that is all we have for our oncology mini lecture. Stay tuned for the next video.